Now it is my pleasure to introduce our presenter today, Dr. Fiore. Dr. Fiore, University of Wisconsin-Hilldale Professor of Medicine, founded and has served as Director of the University of Wisconsin Center for Tobacco Research and Intervention since it was established in 1992. Dr. Fiore served as chair of the panel that produced the United States Public Health Service Clinical Practice Guidelines, Treating Tobacco Use and Dependence in 1996, 2000, and 2008, which provides a gold standard for healthcare providers to treat the leading preventable cause of illness and death in Wisconsin and nationwide. Dr. Fiore chaired the U.S. Department of Health and Human Services Subcommittee on Tobacco Cessation of the Interagency Committee on Smoking and Health that produced a comprehensive plan for promoting tobacco cessation in the United States. Thank you so much, Dr. Fiore, for joining us today.
Holly, thank you so much, and welcome everybody. I feel really honored to have the chance to present to you today and talk with you about treating tobacco dependence in youth and adolescents. And just to give you a preview, when we're talking about tobacco dependence today, we'll be talking about both cigarettes, combustible tobacco, as well as e-cigarettes. So thanks all of you for joining us. Here are the learning objectives for our presentation today, and I'm going to dive right in. And that will be to address the epidemiology of tobacco use, trends in youth and young adult tobacco use. So we're going to be talking about nicotine dependence as a pediatric disease. It's actually a pediatric chronic disease of dependence. It develops in children and adolescents, and sadly, once it grabs an individual, it keeps that individual in their grasp for the rest of their lives. And thus, our management of this chronic disease that starts in pediatric age groups is to control it so that that individual does not need to bear the burdens of that chronic disease in terms of morbidity and mortality. So what are the trends in tobacco use? And it presents, as you can look at this slide, showing data from about 2009 to 2019, an incredibly dramatic contrast with marked declines in cigarette smoking. This is showing rates of tobacco use in 8th, 10th, and 12th graders, with 12th graders in blue. And as you can see among those 12th graders, smoking has gone down from about 20% in 2009 down to below 6% in 2019. The contrast is what we've seen in terms of vaping, such that by 2019, a dramatic 25% of 12th graders were using some nicotine vaping product. Those levels have gone down in 2020 just a bit, but they remain at epidemic levels. So what products are these youth using? When we examine high school students, these are data from 2019, 31% report some use of a tobacco product. Basically 1 in 3 high school student is using some tobacco product, with the bulk of them, 27% of them, using e-cigarettes. Similar to the other slide, about 5.8% are smoking, and you can see the various other products. So the epidemic of tobacco use among adolescents today is not exclusively, but primarily, an epidemic of e-cigarette use. The next slide shows the data from our own state of Wisconsin, where the prevalence lines crossed sometime around 2014. E-cigarette rates went from about 8% to 20% in 2018. In contrast, conventional combustible cigarette use went from about 11% down to about 5%. Again, this dramatic contrasts over time in terms of cigarette smoking among youth, in contrast to e-cigarette use among youth. What products in terms of the e-cigarette landscape are they using? Well, I mentioned that the trends went down. You could see that in this slide. They went down from about 25% in 2019 to about 20% in 2020, reporting use in high school. This probably relates to a number of factors, but they include the Avali epidemic that really got young people's attention, as well as adults, of course, probably unrelated to anything other than an additive to e-cigarettes. But nevertheless, it was a dangerous epidemic, and one that led some high school students, some adolescents, to refrain from e-cigarette use. Thus, we see the decline to 20%. But there are other factors. The age at which kids can buy any tobacco product was raised to 21 from 18. And of course, the COVID pandemic has been a macro influence, including keeping kids out of school, where many of them got their e-cigarette products. So when we look at the sort of products that kids are using, in 2020, they continue to be the Juul-like products, pre-filled pods or cartridges. But what we saw in 2020 was a dramatic uptick in the use of disposable e-cigarette products. And that has importance because one of the other secular trends that we observed over the last year has been the banning of flavorants, with the exception of menthol, from all tobacco products, including e-cigarette products. So Juul no longer was able to sell mango Juul cartridges, for example. But there was an exception in that legislative language that allowed disposable e-cigarette companies to continue to use flavorants, and you can see the variety of them that are on this slide, including blueberry. What we know about e-cigarette use among youth is that flavorants are an absolutely fundamental component of that. And the thought is removing all flavorants from all of these products, all tobacco products, will have a giant impact. Well, let's turn to some of the public health and clinical concerns regarding e-cigarette use among youth. So I wanted to start with some words about what an e-cigarette or vaping product is. And I know all of you have seen these, all of you have dealt with them both professionally and personally in some way or another. But I always come back to reviewing how these products work, because it really gives us an understanding of some of the addictive as well as health concerns. So unlike a cigarette that burns tobacco, literally burns it, generating over 7,000 chemicals, so many of which are deadly. What an e-cigarette product does is heat a liquid to produce an aerosol, and that liquid has in it, among other things, flavorants and nicotine. And the nicotine, of course, is what grabs the kids. It could also, though, be used to deliver cannabis. And you'll see in a moment that increasingly young people are not smoking joints, but are ingesting cannabis using a vaping product. And they've been clearly marketed as cleaner alternatives to combustible cigarette smoke. And the reality is that they are less toxic. They do have fewer chemicals than burning a cigarette, which, as I mentioned, generates 7,000 chemicals. But an important message that we'll give is that less dangerous is not safe. And that's a key distinction. And I want to use that point to make an even broader point. And that is to discuss for just a moment the incredibly divisive nature of the public health discussion around e-cigarette use. As all of us know, there are people that strongly believe that e-cigarettes are a safer alternative to cigarettes and thus should be recommended, including for cessation of combustible tobacco use. There are others who feel just as strongly that e-cigarettes are incredibly dangerous and should not be used. What we do know is that apart from that argument around whether e-cigarettes will or will not ultimately be found to be helpful for adults to quit, there's no public health disagreement that we want no youth to use any tobacco product, including and particularly e-cigarette products. Because once an adolescent brain, the elasticity in that brain is changed to adapt to nicotine, and we then have changed that brain for the rest of that individual's life. And it's for that reason that ingesting any nicotine during adolescence, whether it be combustible, smokeless, hookah, or e-cigarettes, puts that child at risk for a pediatric disease being a lifelong chronic disease of tobacco dependence. So here's a graphic that shows in detail the anatomy of an e-cigarette. We put it in our mouth on the right side, and the liquid that is ingested, that we see when a person is using the product comes out of the left side. So the left side typically has a battery, a simple battery. It's often a lithium battery, but not exclusively. There is then a sensor that allows you to turn the product on or off. There is then the battery heats up a coil, which converts the liquid in this e-cigarette to an aerosolized airborne droplet that is ingested on the right side. The cartridge on the right side is where the liquid, the typically water along with nicotine flavorants and some other additives sits. So that that device, that coil that heats up, takes that liquid and turns it into an aerosol, and you ingest the aerosol. And the new products allow you to ingest that aerosol, not just in the mouth and the upper airway, but actually into the lungs. So a lot of discussion about the chemicals that are in e-cigarettes. I mentioned that the chemicals that are in a combusted cigarette are 7,000 plus. They're probably less than 100 in a typical e-cigarette aerosol, but they include some chemicals that are of importance and are of concern. Nicotine, first and foremost, because it's addictive. There are also, though, ultrafine particles that can be inhaled deeply into the lungs. A really critical point to make about e-cigarettes: we have no long-term data on their health outcomes. So while there's some reassuring data around the damage to lungs, that it may not be horrendous like regular cigarettes, we don't know what happens if one were to use e-cigarettes for decades, as people typically do with regular cigarettes. And if an adolescent were to become addicted to e-cigarettes as an adolescent and continued using them for 30, 40, 50 years, we have no data on that. They've only been around for 10 or 15 years. There's flavorants. There are VOCs, volatile organic compounds, which are cancer-causing. There are other cancer-causing chemicals. There's heavy metals. And propylene glycol is the agent that is primarily used to keep the liquid together. So here's where the challenges are regarding these chemicals. Many of them in e-cigarettes are at incredibly low levels. What we don't know, though, is if those lower levels are in fact harmful or not. Some of those chemicals are at levels that approach those of cigarettes. So we have in the aerosol of e-cigarettes a small variety of chemicals. Some of them have real concerns, but most of them are at incredibly low levels that may or may not be concerning. Here's one exception, though, to that point, and it's nicotine. Nicotine is in e-cigarettes essentially at the same level as in combustible cigarettes. And when a person or an adolescent in particular uses an e-cigarette, she is putting herself at risk of becoming dependent upon nicotine with the lifelong pediatric illness of tobacco dependence. E-cigarettes have evolved dramatically over the last 15 years or so. The first look like cigarettes that you see there's blue as one of them, the first generation. The second generation were these vape pens. They moved to the mod boxes that made so much smoke, and we often saw people in front of buildings using those third generation products. And then more recently, we have this fourth generation, of which Juul is the particularly popular one. It's popular for a lot of reasons, but one of which is its design. It looks like a data stick. It was very appealing to adolescents. It does not make a lot of vapor, so kids could use it in the middle of a classroom. And it became a desirable item for young people to have and to use, and a lot of use in high schools. What we know, and I mentioned this earlier, but I want to emphasize it, is that kids love flavorants in these e-cigarette products. And the names of the flavors and the tastes are, at one point, were an extraordinary variety of appealing adolescent flavors. The companies advertise these. They use, in particular, social media to get the word out. Early in this epidemic, there was a lot of influencers who were using these products, including on the nighttime shows. They were using their influencer capacities on a variety of social media platforms. E-cigarettes became a cool and appealing item for adolescents. The flavorants brought them in, and the nicotine kept them with addiction. One thing that Juul does, which is different than the earlier generations, is that it had a lower pH, which allows individuals to basically freebase nicotine, and it got further into the lungs leading to much higher blood levels of nicotine than the earlier devices. The earlier devices like blue were primarily absorbed in the mouth, the nicotine that was absorbed. You never achieved the blood levels that you achieve with a product like Juul or combustible cigarettes. And so the levels were lower, but also the degree to which it reached those levels with Juul is much higher. It approaches that of a cigarette. And we often say that if you take a drag of cigarette smoke, one's brain is bathed in nicotine within 10 seconds. So it's basically a IV to the brain of nicotine. Juul does almost the same thing. And that's why there's been such high use of this product by adolescents once they begin experimenting with it. Juul also delivers more nicotine. One cartridge, one pod of Juul is the equivalent of about a pack of cigarettes. And that's a real challenge because one thing about smoking a cigarette is it's an easy way to know how many you've had. Taking drags of Juul or another pod system is really high to titrate until the pod is empty. You really don't have the same kind of sense you have when smoking cigarettes. That's not to say that this is a plus of cigarettes. It's just a fact that it's really hard to judge how much nicotine you're ingesting with Juul. Of course, nicotine has powerful physiological acute effects, feeling buzzed, higher heart rate, energy. So one can titrate via those side effects, but it's not as simple as via a cigarette. So I mentioned this earlier, but I want to return to it, and that is this idea that an adolescent brain is quite elastic. And that elasticity allows it to learn, to grow, to develop, and to take on new tasks that one has to do as one moves from childhood to adult. One other aspect of plasticity within the brain is that it allows psychoactive substances, including addictive substances like nicotine, to change the brain, to upregulate nicotinic receptors within the brain, allowing them to grow and develop and have more of. And I often think about, like a little game that kids play of, where they're trying to say, feed me. I've got all these nicotinic receptors in my brain. And if you don't take another hit off your e-cigarette, you feel the need to do so, so that those nicotinic receptors are full of nicotine, and thus not needing to do it again for another few moments. This elasticity continues to about age 25, and we know that heavy youth nicotine dependence can impact cognitive functions, can be associated with psychiatric symptoms, and importantly, it puts kids at risk for polytobacco substance use. We'll talk more about this in a few moments, as well as just broadly substance use disorder. So here's probably what is one of the most concerning aspects of e-cigarette use among youth, and that is it's associated with progression to using combustible tobacco use. One study found that young people who have ever used e-cigarettes were 7 times more likely to become a smoker 1 year later than those who had never vaped. So this progression to e-cigarettes of unclear health risk to deadly combustibles is probably the greatest concern about e-cigarette use by youth. I mentioned this before, but I want to share with you the dramatic upturn in epidemiology around cannabis vaping. And it really parallels the e-cigarette vaping of nicotine that we've seen. Those who have vaped in the last month are much more likely to use cannabis, and there have been really parallel increases in these products over time. So I want to talk a little bit about the health risks of e-cigarettes by themselves, combustibles or regular cigarettes, and then use of both of these products, which we refer to as dual use. So to the 4 bullets on the left, e-cigarettes contain these ultrafine particles and other toxins that may increase acute cardiovascular and lung disease risk. In contrast, smoking is a known leading preventable cause of illness and death in our society, responsible by itself for 500,000 deaths per year in America. 1 out of every 5 deaths directly caused by smoking, and it causes a myriad of diseases, including cancer, cardiovascular diseases, and lung diseases such as COPD. We have essentially no data on the health effects of no long-term data, as I mentioned earlier, on the health effects of either those who use e-cigarettes by themselves or dual use. So we cannot say that e-cigarettes are safe in the long term because they've not been around long enough to make that assessment. Here's what we do know, though, about dual users, both of these 2 products, that as might be expected, they end up having higher exposures to toxicants, but particularly to nicotine. They typically have poorer health, greater difficulty breathing, their asthma is worse, and their COP outcomes are greater. One study of over 4,000 young people aged 13 to 24 who used e-cigarettes and or were not dual users, that these individuals were 5 times more likely than an individual who has not used e-cigarettes to develop COVID. Now, here's what's really important about these data. This is correlational data. This is not causal data. This does not say that if you use e-cigarettes, you're more likely to get COVID. It's just an association that's been noted, probably in part, that e-cigarette use is a marker of a whole variety of risk behaviors. There is some theoretical concern, though, that anything that damages or impacts the functionality of the upper and lower airways puts the person at greater risk for COVID, because COVID protection physiologically depends on a fully functional upper and lower airway in an individual. And if the cilia in my trachea are not functioning correctly, then I'm not going to be able to resist COVID as I would if I was not dealing with that issue. All right, I want to turn now to discuss cessation of tobacco in youth. It is a big challenge, but we need to talk about it because young people deserve assistance just as adults do with cessation. So here's some of the data we have regarding youth tobacco cessation. There's frankly a paucity of research on effective cessation interventions, especially medications for smokers and e-cigarette users under age 18. We actually, in the guideline work, only found 4 studies that use pharmacological intervention, and all of those focused on cigarette smoking rather than e-cigarette use. And treating tobacco use among adults is different than for youth. So here are some of the particular challenges that youth face. The greater influence of peers. Youth are more affected by their peers. They're more affected by their environment, like advertisements. They have also less control over their exposure to tobacco use in their homes. Youth differ in terms of their motivation and readiness to quit. They make fewer attempts. They often don't consider themselves tobacco users, particularly if they're just using e-cigarettes. And they don't believe that it's going to harm them. They see the harms of cigarettes in particular, but all of these products, as something that's going to happen in the distant future when they will have stopped using them and they feel confident that they can. The reality is that EVALI really changed some of those beliefs because they saw their own peers dealing with an acute crisis. Nicotine dependence develops more quickly in youth, even with infrequent use, because of the elasticity thing we talked about earlier. They smoke for the rewarding effects of nicotine, and they can have very similar withdrawal symptoms and intense withdrawal symptoms once they become dependent. The good news is that youth are interested in quitting. 75% have seriously thought about quitting, 2/3 have made a quit attempt, and 40% report having tried to quit at least once and have failed. So I wanted to share with you some of the data that we had in the 2008 Public Health Service Clinical Practice Guideline. What were the key findings? The first is that counseling adolescents and young adults is effective for helping them to quit tobacco products. We found an odds ratio of 1.8, meaning that those who got the counseling were 80% more likely to quit than those who didn't. We had 7 studies to look at, and this was a statistically significant finding represented by a 95% confidence interval that doesn't include 1.0. In contrast, we did not find medications to be effective. There were less than a handful. The results were mixed. Compliance with the study regimes were poor. And we had to, as a guideline panel, say we do not have sufficient evidence to recommend pharmacotherapy for adolescents who want to quit. I'll give you more perspective on that in a couple moments. Surprisingly, and I know to many of our frustration, school-based programs have also not been consistently effective. They seem to have particular impact in elementary school, where kids are very down on smoking, and particularly among their parents. By the time kids get to the peer influences of adolescence, these elementary school influences fall to the wayside. And most programs have not been effective, although some, like the Lung Association program that I'll mention in a second, does have some data to support it. Here's the most important way to prevent and discourage and promote cessation, and that is via policies. Kids are much more sensitive to price, so if we increase the price of tobacco products, including e-cigarettes, kids will be less likely to start using them and will be more likely to put them down and not purchase them. Access is important, thus raising the age to 21 has been a really powerful effort. Clean indoor air policies denormalize smoking, and that has impact even with adolescents. And finally, media campaigns like the FDA's media campaign are so powerful. And while I wanted to show you some examples of that FDA media campaign, it doesn't work well on a WebEx. But as you'll see the link in a moment, I really urge those of you who haven't seen them to examine them. They're updated every 6 to 12 months, and they're really powerful. All right, turning now to what works and some promising practices. So here's what we know about adults. We know that advice helps. We know that counseling delivered via a variety of modalities help. We have 7 FDA-approved medications for smoking cessation, and using them in combination particularly is helpful. Removing barriers and having insurance cover smoking cessation helps. And if we integrate it into health systems, it's more likely we'll deliver smoking cessation. And that has relevance because of so many smokers visit a healthcare setting, greater than 7 out of 10 each year. So how does this apply to youth cessation? Well, the American Academy of Pediatrics recommends adopting interventions found to be effective with adults to children and adolescents based on their developmental needs. So what the American Academy of Peds basically said is, we may not have enough information on youth, but let's just use what we know helps with adults. In terms of what is happening in clinics and high schools, advice from clinicians to youth, it's not happening consistently. So students who visit a healthcare provider during the past year were asked the rates at which they were asked if they used tobacco, only a quarter to 46%. That's among high school students and middle students. These are kids who have visited a healthcare provider. So less than half are asked if they use tobacco, a real problem in the pediatric setting. And in terms of students who smoked cigarettes within the past 30 days, what proportion of them were advised to quit? Less than a third. So we are dropping the ball in terms of asking our youth about their tobacco use and then helping those who use tobacco to quit. Using the 5 A's from the PHS guideline is a good model that can apply to adolescents and young adults as well. The first is asking every adolescent, every time you see them in a healthcare setting, do you currently use tobacco products, including cigarettes, vaping devices, cigars, or smokeless tobacco? So that broad question will identify those who are using tobacco, and there's pretty good rates of self-disclosure in a pediatric healthcare setting, particularly if the parents are not in the room. Advise them in a clear, strong, and personalized way. These are now among those who use tobacco products to stop. And this gives some draft language that you could use, but it's really important to focus on some of the short-term benefits of quitting because those are more likely to resonate with teens, that you don't taste good, you have bad breath, nobody will want to kiss you, and it will cause premature wrinkling of your skin. Assess their readiness to quit. You're willing to give it a try in the next 30 days, and how confident are you that you'll be able to quit? And then finally, as I mentioned, the guideline identified counseling as very effective for adolescents. And this counseling could be cognitive behavioral interventions like coping and problem solving. It can be motivational enhancements that I'll go over in a moment. And finally, the importance of social influence, to learn refusal, help them to learn refusal, assertive skills, tell about the tobacco industry and how they promote and try to entice them, and take advantage of media and peer social influences that are in the positive direction. Try to help them to set a quit date within 2 weeks, not some distant time in the future. Don't pick a time of stress such as exams. Anticipate check. Any adolescent 13 and older can successfully use these products can successfully call the quit line. They serve anyone who is 13 years or older, and that will be shown in the next slide. They're available 24/7. It's free, it's confidential, it's tailored to their age group. And the number is 1-800-QUIT-NOW or 1-877-2-NO-FUME for Hispanics. All right, so what's available when an individual calls the quit line and they're a youth or young adult? There's a quit coach available to talk to them. There is web-based support, so you can get a web coach. There's a texting program available. Materials will be sent to the individual's home. And if they're 18 or older, they'll receive 2 weeks of the nicotine patch, lung, gum, or lozenge, whichever they choose. If they're under 18, they're ineligible for nicotine replacement therapy. I also want to highlight smokefree.gov. This is managed by the National Cancer Institute. It's the most popular website for smoking cessation in the world, and it has a lot of resources just for adolescents and young adults. So there's a smoke-free text program, there's a smoke-free teen program, there's a smokeless tobacco text program called SPIT. So it's a dip-free text program. And there's also via a nonprofit called the Truth Initiative, a quitting program for e-cigarettes called Ditch Juul. And if you text that, you can get access to their texting program to quit e-cigarettes and specifically Juul. So let's talk a little bit more about medications. This is, I know, a challenge that all of us face when confronted with an adolescent who is using tobacco. If they're 18 and older, you use you use medications without any reluctance. But for those under 18, as mentioned, there's limited data. But here's what the American Academy of Pediatrics recommended, that you consider off-label NRT use for youth who are moderately or severely addicted to nicotine and motivated to quit. So basically it's saying if you've been unable to get that person, help that person to quit, and they're clearly using a lot of tobacco products, whether they're e-cigarette or cigarettes, you could consider using NRT. Now, that consideration is not based on studies that support it, but based on it just makes clinical sense. Cigarettes in particular are deadly. We want to get kids off these products using nicotine as a bridge from tobacco products to neither tobacco products nor medications. And the sooner you do that, and the sooner the young person is able to do that, the less likely they've permanently changed the architecture of their brains. These are the 7 FDA-approved medications, 2 non-nicotine and 5 nicotine agents. I'd urge nicotine if you're going to use one. We have more experience with that, and we already know that kids tolerate it. Well, what about an adolescent who is not interested in quitting at this time? Well, let me just get that off the screen here. You can talk about what we call the 5 R's. Identify the personal relevance of quitting for that individual. Discuss what the risks are of continuing tobacco use. Explore what the rewards for that young person would be to quitting. What roadblocks are keeping them from quitting at this time? And finally, repeat it, because they're not necessarily going to respond to the first time you address it. The last of the 5 A's is to arrange follow-up, because what we know is if you continue the conversation, particularly if they have set a quit date, the adolescent is much more likely to go through with their quitting plan. It's a big problem to keep kids focused on this. So follow-up is particularly important with this population, and also helps to deal with if they've already relapsed, to come up with another plan that will help them. Just continuing to emphasize the importance of thinking about quitting. I mentioned earlier the FDA's real cost, and one variant on it is called Fresh Empire. You can go to betobaccofree.hhs.gov and see these and share them with young people, as well as to get a handle on what they're seeing themselves. The FDA spends a ton of money getting these ads in the face of adolescents and young adults, and they do a very effective job at it, particularly targeting it to the social media platforms where adolescents and young adults are. So to summarize, these are some key takeaways. Both e-cigarettes and other vaping products have a unique set of health risks and increased risks of progression of combustible tobacco use for youth. So as I said at the start, while people may differ on the potential of e-cigarettes to help adult smokers, there's no question among adolescents that we should discourage their e-cigarette use for them unequivocally, for all of them. There's no place for e-cigarettes for young people. Half of youth who use tobacco products are interested in quitting, have tried to quit, so you can talk to them and build on that, and particularly try to provide them with some skills that will allow them to successfully overcome tobacco products. And finally, counseling and behavioral interventions are effective in preventing and treating tobacco dependence. So the counseling strategies we talked about earlier can be very effective in helping young people to quit. Here are a bunch of resources for providers of various types. I would also just urge you to go to our center's website, www.ctri.wisc.edu. All of these resources are up and available, but there are some additional ones below. The University of Wisconsin Center for Tobacco Research and Intervention has outreach specialists located in the 4 quadrants of our state. Here are the names of these individuals. Feel free to reach out to them as a resource for you. They are in service to the state to help both youth and adults to break free of tobacco addiction. Feel free, take their email addresses and contact them about how you could utilize them with your programs. We're in a world of COVID where everything now is being done virtually. They're able to do interventions and presentations virtually, and hopefully soon we'll be on the other side of COVID, and they'll be back out in the field in person as well. So thank you again for inviting me to present today, and I'm happy to take any questions.
Thank you, Dr. Fiore, so much for sharing that information. I think whether you're in public health and focused on prevention, or a clinician who's focusing both on prevention and cessation, there was information that that people come away with to benefit how they can better address and help youth to quit tobacco. So before we get to your questions, I just want to remind attendees that there is a link in the chat box to the slides, as well as resources from the American Academy of Pediatrics. And we really urge you to take a look at those resources, because they provided more information than what we had time to cover about cessation counseling for youth and adolescents, as well as dosing medications, and that's, I know, a particular challenge, but it provided some guidelines around dosing of medications for youth and adolescents. So you can go to that link to download that information, and then there's also a certificate of participation at that link that you can submit to your professional organization for CE credit for attending today's webinar. We've also added some links in the chat box that will direct you to youth cessation information on the CTRI website. So let's take a look at the chat box and see if there are any questions here. I know you had mentioned earlier about school cessation-based resources having kind of inconsistent research on effectiveness. A lot of research focused more on prevention programs, but still kind of inconsistent. Could you talk a little bit more about that and I think you had mentioned the ALA's NOT program, Not on Tobacco program.
Yeah, the National Institutes of Health over the last 30 years have funded just an enormous array of school-based programs that followed kids from elementary school all the way into adulthood. And, to all of our disappointment, those programs had limited impact in terms of preventing kids who are exposed to them from starting to smoke at rates different than those who weren't exposed to the program. That's how the studies were designed. Of course, none of these studies were done with preventing kids from starting to use e-cigarettes. They were exclusively combustible tobacco products. But I want to highlight the Lung Association's NOT program because I think that has data to support it. And education, even if we don't have overwhelming evidence of its ability to prevent ultimate tobacco use, I think that kids with information are empowered in a way that those without are not. So while that would not be my main focus, I think that there is no downside to informing particularly adolescents of the dangers of tobacco, as well as the ways that they can choose to quit if they want to engage in it. The impact of EVALI can't be emphasized enough. EVALI was probably the result of not what's in an e-cigarette product you buy over the counter, but rather what kids added to it that was really dangerous, including oils. So while that was the cause of it, what the message was and what kids believe is that all of a sudden e-cigarettes, which were just a fun product, actually could be dangerous. And building off of that, I think has power as well.
One aspect of e-cigarettes that I think contributed to the skyrocketing rates of youth use is the lack of regulation. And I was wondering if you could talk a little bit about where we are with FDA regulation of these products.
Well, it's a evolving situation in that they've only been around for a few years, and FDA is regulated tobacco only since 2009. But we've had a couple really good things happen. One is the age of purchasing tobacco has been raised to 21. And that has importance because so many adolescents reported their older seniors in high school who had turned 18 as their vehicle to get access to e-cigarettes when the purchase age was 18 and those kids were able to buy these products. That no longer is the case. That's a big deal. The flavoring ban, while it's not complete, and that is very disappointing, it at least has made some of it more difficult to get. And removing flavorants we know will matter. And then finally, all e-cigarette companies this summer have had to submit to the FDA a packet of scientific data to support their perspective on their right to continue marketing their product. It's a complex system called deeming, and they all submitted their packets this summer, and the FDA has till next summer to review those packets, and based on that, they will either allow the companies to continue selling their products, they will say they have to ban the sale of their products, or something in between. They have to do it with additional information or under certain circumstances. So by next summer, we're going to have additional guidance from the FDA as a result of this deeming process.
Okay, and Amy has 2 questions for you from participants.
Yeah, so the first question, comments and questions. So this has been excellent. Thank you so much, Dr. Fiore. I am in peds and help many kids that vape and parents that vape or smoke. I write prescriptions for NRT because it's cheaper. Have you heard of issues getting NRT prescriptions covered for minors? Thank you again for sharing your expertise.
Oh, thanks. It's a great question. I've never heard that there's been any limitations. Of course, while nicotine replacement products have been tested and approved for individuals 18 and older, as any licensed prescribing physician or clinician, we could choose to use FDA products however we deem appropriate. So there should be no limitations. Each insurance plan, of course, can have their own rules and regulations, but there should be no limitations based on age in general. Next question, Amy.
Great, thank you. And then just to verify, do all e-cigarette products contain nicotine, or can there be some differences with that?
So e-cigarette products differ markedly. Some types of e-cigarette companies actually sold e-cigarettes with 0 nicotine. Some sell e-cigarettes with varying levels of nicotine. Nicotine is the base product, though, because it's what keeps people coming back for more. It gets kids and adults hooked and keeps them coming back purchasing the product. So I would also say the products differ dramatically. Some of the products, you add your own set of ingredients, including nicotine or not, and flavorants, etc. We all know about the vaping sites that are in many communities. So it depends on the product, and there are some, but most have nicotine because that's what keeps people buying more.
Well, thank you for those questions, Amy. We wanted to give a special thanks again to Dr. Fiore for your presentation today. And on behalf of the UW Center for Tobacco Research and Interventions Outreach Program, we want to thank all of the all of you for attending today's webinar. At the conclusion of the webinar, we have a 2-question evaluation that's going to pop up, and we'd really appreciate your feedback. So thank you again for joining us today. Have a great day.
Thanks, everybody, for joining. Bye-bye.